all that said, I'm going to do a mini lightning round, okay? Here it is. It's like a game show. So first-line treatment of metastatic disease, right? Our goals are palliation, making the patient feel better. Everybody agree? That was the first test, lightning round. Okay, so then the question is, we have a bunch of chemotherapy agents. We have a bunch of different chemotherapy options we can use. What is your go-to regimen, first line-ish?
So I think a doublet. So a platinum 5FU doublet like FOLFOX, I think, is commonly used. Just a minute on that, though. So with the other options, so if you think of taxanes in the second-line setting, ramucirumab, irinotecan, maybe a PD-1 inhibitor coming in on board, I actually think that for some patients it might be advantageous to use like a modified 3-drug regimen in the first-line setting if it's done safely, because you want to have every drug available to them. Similar to colon cancer, what we learned is that the more drugs patients get, the longer they're going to survive. So I think my go-to is FOLFOX, but you know, I'm thinking about how we can incorporate more drugs overall.
Love it. Ian.
So we have a lot of thoughts when second-line paclitaxel start to become routine use, and we have been concerned about the neurotoxicity from oxaliplatin. So there was a period where we were using the triplet EOX, epirubicin, oxaliplatin, capecitabine as a standard, and we have actually changed and stopped and switched the oxaliplatin back to cisplatin. Mainly to try to preserve the nerve for as long as possible. So again, yes, I mean, we do give patients epirubicin, cisplatin, capecitabine, so the ECX regimen, or sometimes we, as I said, there are many occasions where we only give doublet. So will be either cisplatin, capecitabine. We do use a lot of carboplatin actually for our older age group and things, and that's probably quite a long tradition that we've been doing it, and a lot of older folks with comorbidities actually really tolerate that well. But you know, it is probably a niche thing that we do a bit more often maybe than other institutions. But for those who can't swallow, I do use FOLFOX a lot for those who we really feel that they can't get the oral intake. You know, I know we again. Perhaps not in the license of capecitabine, we do dissolve it, but even if they can't, we're not certain they can get all the drugs in, then I do go to FOLFOX.
Okay, here's a quick question. Do you ever play, so the classic 5FU and cisplatin regimen, the infusional 5FU is a big old dose of 5FU for just a few days and a big old dose of cisplatin, and you give the patient some time to chill out. In the setting of being palliative, looking at quality of life, have you ever modified some of these dosing regimens?
I certainly don't use that regimen, okay? But that's because, again, you know, because we have the ECF. So the 5FU was given as low-dose continuous infusion every single day. So we don't give the 5-day big bolus dose, big soft dose of 5FU infusion. So we certainly, when we do need to give continuous infusion 5FU, we do the low dose together with cisplatin or carboplatin. But of course, we say all that in a HER2 negative patients. I mean, I know we haven't actually touched on HER2 positive yet, but you know, all the things that we talked about is of course for HER2 negative gastric cancer.
Gotcha, and we'll come back to that.
Yeah.
Yelena.
Okay, well, I'll throw a curveball. I would argue that gastric cancer in U.S. is rare, so every single patient, if fit and if a trial is available, should be treated. And in my practice, I would say that the majority of the patients are fit, and so a clinical trial is where really we start. But outside of that, I would go by the patient's baseline, comorbidities. So in a patient without significant neuropathy, 5FU platinum is what I would recommend. So Degramont infusion 5FU, so modified FOLFOX 6. But now in a patient, who has neuropathy or diabetic or violinist and cannot even bear to get any neuropathy, there's data to support FOLFIRI. In first-line setting, it was compared head-to-head against a triplet and has done just as well with less toxicity. So although it's very rare, but it is supported to use FOLFIRI in first-line setting.
Excellent, excellent.
Can I make
Yeah.
one point, what Yelena just said about, I think nowadays we shouldn't just think of the violinists need their fingers. You need that for your iPhone. You need that for your iPad. Actually, I find there are, relatives who actually get chemotherapy and say that their life completely destroyed because they can't use their smartphones anymore. So actually, nowadays life has changed. We can't just think of them just, musicians. Now that everyday life, they need their fingers.
Yeah.
But then you will have patients that say that their life is better because they can't use their iPhone.
Now, what about HER2?